All right, thank you everyone for joining us today. We're really glad to have you all for the March Lunch and Learn. We're going to talk about the integrated SEPs and a little bit the special enrollment periods and take your questions on D-SNPs if you have any left. And then we're going to have just open question and answer and war story time if we have any time left. So that's our plan for today. As we get started, I just wanted to talk about the integrated SEPs for just a minute, and you all should have this information or access to the information on the integrated SEPs. It was in the October CE workbook, and I'm going to get the link for you for that. Hold on just a second. So you can get the CE workbook from our site if you don't have it, and be able to, have your own copy at home of what I'm going to share in the screen in just a minute. And then also, if you're looking for the recordings from the last month's Lunch and Learn, we have most Lunch and Learns haven't been recorded, but we have a few Lunch and Learns. We finally have the recordings up on our YouTube channel. So I've shared the YouTube channel. We have some other recordings there as well. We have a few of the Lunch and Learns from last year that we recorded. Which one was the buy-ins with Dina, I think, and the session that Johnny did on D-SNPs last March. And then there's a few other trainings there. There's a Plan Finder tour showing some of the Plan Finder features and things like that. All right. So in the October workbook, we had an example or a chart showing all the D-SNP SEPs. And the crux of it is the quarterly changes that we had last year are gone. Okay, for people who could change their plans quarterly, that's gone. It's not quarterly anymore. It's now a monthly basis for the people who can make their changes.
And this is David. When you share screen, you change the view. So now I don't know where the interpreter is. When you start sharing screens and stuff, you do need to give a moment. Also, this is the interpreter speaking. It would be helpful if you gave the interpreters and David multi-pin so that he's able to pin both interpreters so that he's not losing us. But yeah, when you share screen, just then give it a moment because everybody needs to readjust their view.
What's the second interpreter's name?
Madison, is she here?
Yeah, I'm here. Hi.
Oh, there. Okay. Hey, you all have multi-pin. Okay, are we okay?
Okay, we are.
Thank you. All right, so we have in the October workbook, and I shared the link in the chat, from pages 19 and 20, we have a chart that shows the new special enrollment periods. Basically, anyone can go back to original Medicare and a Part D plan monthly if they have extra help. So that would be anyone from full dual eligible, partial dual eligible, and extra help only. Our difference is that people can only change their Medicare Advantage plan or a D-SNP plan if they are doing it to go on to a D-SNP plan that's in alignment with their mental health benefits. Okay, so they can only do it to align their mental health benefits with their medical benefits. They can't do it because they want better dental coverage or they want to be able to go to a different gym. Okay, people can now only change their Medicare Advantage plans for other reasons beyond bringing their mental health benefits, their Medicaid mental health benefits, and their medical benefits in alignment. The only time they can make a change to those plans is during Medicare Advantage open enrollment or during open enrollment for the following year. It's just like everyone else.
Noreen, so to try and put that into practical terms, so I was thinking we only had one behavioral health provider. So are there multiple behavior health providers, or how is that going to work? I mean, they're going to have a separate card, and so we know that they can change to that Advantage plan, or maybe some more concrete examples of how that might go into play.
Sure, Vanessa or Johnny, do you want to help out with this?
Sorry, couldn't unmute myself. I'm not sure if Johnny is here yet.
Yeah, he might not be here yet.
Yeah. So my name is Vanessa and I work at DSHS, also Home and Community Services. And just a little background on me. I'm the Medicare Medicaid Integration Program Manager over at DSHS, and collaborate with SHIBA OIC and other community sponsors that have the SHIBA contract in addition to AAA's throughout the state of Washington. With regard to the specific question, I personally, the way I discussed this special enrollment period, you can do it monthly. You can no longer do it quarterly. That is in the past, effective 1/1/2025. You can make a change to your Medicare D-SNP if the intent is to align it with your Medicaid coverage. We're really talking about those full duals. So what I mean by that is alignment is, let's say you have a Molina Apple Health Medicaid plan, but you have, let's say, Humana for your Medicare D-SNP, but you want to align that coverage so it's all under one insurance company, knowing that Humana doesn't have a Medicaid contract. So that would be the change, would be to your D-SNP, and you change to a Molina D-SNP. Now you're in alignment. If the purpose is for any other intent outside of that, you can't do it. And as Noreen stated, you can do it, let's see, right now, right? Because we're in the Medicare Advantage open enrollment period through the end of this month. Or as she stated, you can wait until the annual open enrollment period. But I don't get as technical as to go into the BHSO part of it.
Yeah.
It's literally, it's your Medicaid. You're wanting to align your Medicaid with your Medicare D-SNP. And let's say vice versa, if you're on a Humana D-SNP and you want to align, it doesn't have, that is the only MA plan in Washington that does not have the Medicaid contract. So that's the plan you would have to switch. It would be a reverse, right? You want your D-SNP to align with your Medicaid versus Medicaid aligning with your D-SNP. But either way you go, as long as it's for the intent of alignment of both your Medicare and Medicaid coverage for a full dual, you can do it monthly.
And so just to, because I'm no Medicaid expert, to understand when you say your Medicaid is with, are you talking about the administrator of your Medicaid benefits, or what does that mean?
So Apple Health, Medicaid Apple Health, it's through the Healthcare Authority, which is the Medicaid contracting agency. Like, they're the ones who oversee all these contracts. And what they've done, just like with Medicare Advantage, is they have contracted with the 5 different Medicare Advantage plans in Washington state, but they also have an IMC contract, which is specifically Medicaid. So those same insurance companies that offer a D-SNP, they also, with the exception of Humana, offer an Apple Health Medicaid plan as well. That's what I'm talking about. It's Apple Health. So it's, and again, Medicare is going to be their primary. We're talking full dual eligible. And then you've got the Apple Health, which picks up whatever Medicare does not.
Okay, so any client could be enrolled in multiple Apple Health providers. there's not just one that the state is contracted with.
So I'm gonna, so I'm gonna simplify it to make sense, because the language that I just heard is a little confusing to me. There are insurance companies in Washington State that the state Medicare agency is contracted with, and those are like Molina, United Health, CHPW, trying to think, Amerigroup, WellPoint is their name. But they have those contracts with those insurance companies to administer the Medicaid Apple Health benefits. Does that
Got
make
it.
better sense?
Yep, that does now.
Okay,
Okay, thank you.
you're welcome. David, I see your hand up.
Yes, hello, everyone. I was wondering, I wanted to clarify. A few days ago, I was reading information about statewide Medicare programs and the cuts that are coming. So for our state, safest, I think Apple Health is potentially going to get cut, correct?
No,
Have cuts?
no, I don't believe so. I haven't heard that myself. I think there's a lot of misunderstandings about what is being cut or what isn't, but Apple Health is not going to be. We're kind of getting the information at the same time most everybody else is, unfortunately. So I can't speak to that today. Maybe if Johnny, if he's able to join us, he might be able to speak to that a little bit more. But Apple Health is not being cut.
Okay, we have a question from the chat
for
too
that.
that we're gonna address. Tina asked, when someone in an Advantage plan already and then becomes eligible for MSP as a QMB, can they make one initial change to a D-SNP? If so, what is the window of time to make that change?
Okay, I'm gonna have to look on the specifics as to what that window of time is, but
Yeah, it's 90 days.
yeah. Okay, there you go, Noreen. Thank you.
Yeah, they're new to benefits, Tina, so they get a 90-day special enrollment period.
Thanks, Noreen. That was that was especially I needed to know how long. Thanks.
And then we have another, and Vanessa, thanks for just jumping right in before I even got to introduce you.
No, it's totally fine.
And doing your introduction. Okay, so we have a question from Elena. Are all in-network D-SNP providers, do they accept both Medicare and Medicaid? Does this apply to both the HIDE and CO D-SNPs?
Yeah, so plans are working on that. I know the vast majority. So we're trying to get alignment, right? Where providers, like, that's why we want alignment, because the assumption would be that if you're on Medicaid Apple Health and you become eligible for Medicare, that you could go from your Molina Apple, I'm just using them randomly as an example, but you can go from with your Molina Apple Health and you can enroll in a Molina D-SNP plan. And the hope is that they've already contracted with both Medicaid providers and Medicare providers, so it shouldn't be a huge adjustment or transition where you're scrambling for a new provider. Now, I will say if you're living in like the metropolitan area, like King County, Seattle, it might be a little bit easier. If you're living in a rural area, I mean, there's still probably contracting going on. I know they're actively working on their contracts to have providers that accept both Medicare and Medicaid. I can't guarantee it's going to happen 100% across the board, but that is the intent and the goal that we are working towards. So I would say most of them are contracted with both, but it's not 100% across the board yet.
So let me be sure. So it's still beneficiaries' responsibilities to assure that their providers accept both Medicare and Medicaid at this point, even if they have D-SNP.
Yeah, I would say that for anybody, even if somebody isn't on a D-SNP, always, especially this time of year, these Medicare full duals are going to have a provider one card. They're going to have their managed care organization card. and they're gonna have their D-SNP card. And I would just say, take all 3 cards if you've got 3, or maybe you only have a provider 1 for a partial dual and a D-SNP card, but take all of your information to the provider to make sure that they understand I have Medicaid Apple Health, but I also have Medicare D-SNP, you know, and make sure that they understand the difference, because some might be contracted with a Medicare D-SNP, but they're not contracted with Medicaid, or vice versa. We run into that more often than I'd like. But again, it is a process that we're actively working with the plans, and we, you know, check in with them quite often where they're at with expanding their networks.
Okay, our next question is from Abby. From a practical standpoint, when or why would someone choose to remain in a non-aligned D-SNP? Would that be because a particular behavioral health provider is outside of the aligned plan?
So it could be. I mean, they could have a preference, and the D-SNP may have worked better for them. I think the one plan you need to be aware of, again, and I'm going to bring it up again, is Humana. They do not have a Medicaid contract. So there's no way to align that plan with Medicaid. That's, that's the coordination only plan.
So
Yeah.
maybe I think it might help us all if we take a little bit of a step back. So about the Medicaid and the Medicare part of it. Okay, right? Because when people are on Medicaid before they turn 65 or become eligible for Medicare, before they've reached their eligibility, they could have a plan through one of these insurance companies, right? Could you kind of explain that transition for us, Vanessa? Like how their coverage changes once they become Medicaid eligible, and then how the D-SNP is kind of integrating that.
So I'm not totally sure I'm understanding the question, but what I can say, there is a transition from Medicare to Medicaid, whether you're aging into it and you're on Apple Health, or under 65 due to a disability. Now you can carry over your excuse me, you can carry over your Apple Health. You don't have to change it. If you're full, you can maintain that Apple Health plan that you're currently on. Sometimes people just don't know to align their coverage. Alignment, it has been really, it's been a big push for the last couple of years. It doesn't mean everybody is aware of it. It doesn't mean that everybody is aware of the benefits of alignment. And the reality of it is people often, when they're trying to figure out, okay, I'm eligible for Medicare, people are still learning about D-SNPs. Maybe they do know about a D-SNP and they enroll in a D-SNP, but it's with a different insurance company than their Apple Health. Again, they just don't know to align. And the reason for aligning, one of the benefits would be to streamline and just make it an overall easier process for not only the member, the client, but also for the providers, because they're having to deal with only one insurance company versus 2 different insurance companies. And then the fact that the hope is, if it's one single entity as the insurance company, but just 2 different plan types, that internally that communication is going to be better, which again, then just streamlines the process. Right now, we know it's a little bit lumpy when we're dealing with 2 different insurance companies, one for Medicaid, one for D-SNP. They're not always talking as they should. And that goes even down to like providers that are pharmacies that are contracted as well. So again, it's just getting the word out about alignment and understanding how it can be beneficial. I don't know if that answered the question, but if it didn't, just let me know.
I have a question. I can't find my raised hand, but this is Maureen. I have a question when you have a chance to answer.
Sure.
And thank you, Johnny, for joining us. We have another question in the chat too, that just before Maureen. Larry's wondering, what are the behavioral health insurers in Washington State? So how does that work?
Johnny, do you want to take that one?
I apologize. Let me understand the question a little bit more, if I may. Are you asking who our behavioral health services only plans are in regards to dual special needs clients, Or was the question different?
Larry, you want to unmute and ask it?
Yes. Yeah, the former, the behavioral health providers where there is separate coverage that you're trying to align. What are those companies and how much overlap is there with the other Medicaid insurers?
So that's a very good question. Let me back up a little and just share this from this perspective. The state of Washington is what's called a mandatory managed care state. So when a client becomes eligible for Medicaid, they are assigned a behavioral health services only plan. So they have to be fully eligible for Medicaid. They will be assigned, or they may select a behavioral health services only plan. These behavioral health services only plan is managed Medicaid for their behavioral health services. And these are the same plans that currently offer the integrated managed care for Medicaid eligible individuals. So it would be WellPoint, Coordinated Care, United, Molina, and Community Health Plan of Washington. When it comes to the alignment portion, and I'll answer the question from Dawn as well, when an individual selects to join a dual special needs plan, the goal is to have them ensure that they are looking in their county and identifying the dual special needs plan that also offers the behavioral health services only plan that they are currently enrolled with. This will align their behavioral health and will align their Medicaid and their Medicare services, specifically the behavioral health services. So again, when we're looking at, say, an individual that has a dual special needs plan, Medicare covers a certain percentage of behavioral health services, from substance use to mental health counseling. There is some overlap in terms of how that coordinates with their behavioral health services only plan, and that by aligning those two plans, that ensures that that coverage is wraparound and covers all the necessary both Medicare and Medicaid benefits. Does that answer your question, Larry?
Absolutely. Thank you.
And Dawn, did I capture yours as well? There are only
You did,
five.
it didn't really capture it. Is that it sounds like I'm a SHIBA volunteer. So people who come to me are saying things aren't working. I don't know why. So that's where my understanding is coming from. So what I was trying to do is that this is something that we're not going to deal with at SHIBA. It sounds like if a person needs to do alignment, they have to go do it themselves. They have to understand it, and they have to be directed by DSHS to go ahead and do it. Is that correct?
Well, really, it just comes down to when they're enrolling a dual special needs plan, they just go and look at what behavioral services only plan they're assigned at and look for the corresponding D-SNP. So if they are if they have coordinated care as their behavioral health services only plan, then they're going to align that with WellCare and say that is WellCare coordinated care. I want that aligned, so I'm going to enroll with the WellCare D-SNP so that I have WellCare for both my WellCare coordinated care for all of my services.
So who tells them that that's the process they should go through?
They would go through Medicare.gov. So when they enroll in a behavioral health services, when they enroll in a D-SNP, that's their choice. They're not.
So how do they know to enroll in the D-SNP?
Folks are not directed to enroll in a D-SNP during the open enrollment period. They receive lots of, I want to say, marketing from various folks, and some of that marketing coming to them will say you're a dual special needs plan. We're a dual special needs plan who coordinates with your Medicaid, and it will give them options. Ultimately, we would like we also have information on our website that identifies the D-SNPs that are offered, so they can see which of them actually work with the state of Washington. So there is maps on the HCA website that they can certainly look at to find a dual special needs plan that they can coordinate with.
Okay, well, thanks. I've got some more questions, but let's move on. Well, I'm done. Thank you.
Okay. I see, David, you've had your hand up for a while, and then I can start going through some of these questions in the chat box.
Sure. Yeah. I just wanted to make a comment about behavioral health, mental health. So related to Medicare and Medicaid, but not talking about working for behavioral health recovery systems. So that is for community basic analysis under DVR. And that is putting in all the data, making it accessible to what permission? To gun permissions. To fill out the data that's accessible for people to make decisions for who is qualified to receive a gun license. And
You-
I've noticed that there is not a lot of comment about gun permits within the behavioral health discussion. So I wanted to add that comment.
We're certainly not going to comment in terms of gun permits and how that relates to any of the legislative activities for their criminal or other types of cases. This is related specifically just to their behavioral health medical needs. So when we talk about behavioral health, we're referring to substance use disorders, referring to mental health issues, not so much recovery of rights or any additional other non-medical related behavioral health resources. Trying to be very explicit to say
Yeah.
we're not going to address gun rights.
Yeah.
Abby,
we
I
have-
see your hand. Oh, go ahead.
Yeah. Oh, thank you. Just really quick, and this is kind of for Noreen too. Well, and Johnny, you mentioned there's this on the HCA website. There's a list of D-SNP, there's a map of D-SNP areas. If there could be some coordination between the HCA data, the documentation or resources, and SHIBA, that would be helpful. But this is just a comment that we're having, as a SHIBA volunteer, I'm having a hard time grasping all of this slowly, but most people with whom I've spoken never heard BSO. They're just they wouldn't necessarily know that they have a BSO or what BSO they have. At least that's my experience. And I have worked with folks who have been on Medicaid for so long or Medicare due to this disability and were prior to BSO. And so their coordination has been really, they've had a real challenge. So it's just my limited experience. Other people might have worked with folks who really are quite aware of what they have and don't have. I just want to make that comment.
So the integration model that we're currently working through has been outside of Medicare. So setting Medicare portion and D-SNPs aside, the integration model that we're operating has been over 10 years in process. So, for example, we began the alignment journey, I would say, in the early part of the 2010s. And that included for individuals who were Medicaid. We, HCA, the state of Washington, integrated your managed care in a way where the integrated managed care for folks that are Medicaid eligible received both their behavioral health and their physical health under the same managed care plan. It started in Clark County and expanded year over year into different counties until 2019, 2020, when it expanded statewide. At that point, an individual across the state who was in managed care or Medicaid had the same managed care plan who covered their behavioral health and their physical health care services. For individuals that were Medicare, they were assigned a behavioral health services only plan. This again covered their behavioral health services. It was again different than what was done before, because before you had your RSNs, your regional service networks. I think that was I think that was the acronym for RSN. And then for a while you had behavioral health organizations, but again, that transitioned into integrated managed care. So an individual who was fully Medicaid eligible now had one plan to wrap around their entire health needs. But for individuals who are Medicare eligible, they were original Medicare and were assigned a behavioral health services only plan. That again helped them connect with their behavioral health Medicaid needs on top of their Medicare services. So as we have transitioned more into D-SNPs, we're aligning D-SNPs and behavioral health services only plans in a way where the two of them connect and can coordinate those same services to identify those gaps where Medicaid has stepped in and ensure that Medicare and Medicaid are working hand in hand to provide coverage for covered services. So Abby, I understand where you're coming from in terms of phrases like BHSO are sometimes not out there. Most people think of Medicaid as just their managed care plan. But for the purposes of our Medicare eligible individuals, their physical health and some of their behavioral health are going to be covered by Medicare. Medicare is the primary payer, and then Medicaid overlaps that. Does that help explain a little bit, Abby?
A little bit. It's going to be in practical application.
Right,
Yeah.
I understand there.
This is Maureen, and I can't raise my hand, so I just want to let you know that I'm in the queue for a question.
Yeah.
Okay.
And there's a question in the chat that I think might help clarify this a little bit before we go on. And the question is it difficult to change behavioral services plan if they choose to go to a different D-SNP company?
It's actually more difficult to change your D-SNP than it is your BHSO. For your BHSO, you just need to follow the process for changing your Medicaid plan. You can do that monthly. There's no limitations. You can just go in, change your plan, and then you're good to go moving forward first of the following month. So if you want to change your plan today, I know it's the 6th, but if you want to change your plan from coordinated care to CHPW, you could do that today. It will take effect April 1st, but you can do it at any time. Let me put the information around changing your plan in the chat box.
Thank you.
QMB, I'm going to just touch on that one. I see your question, Tina. For a QMB not full, do they have a behavioral health services only plan? If not, does that mean there's nothing to coordinate, align, and therefore there is no opportunity to change plans during the year? You are correct. An individual who is just QMB is only partially dual. So they are in the Medicare savings program, but do not have full Medicaid. So they are not assigned a behavioral health services only plan. The opportunity to coordinate, align does not exist for them. So they are able to choose they should choose whatever plan best fits their needs at that time. Tina, did that answer your question?
Yes, so basically QMBs don't change. I mean, only full duals can change every month. Is it
According to the new rules, correct. They
on the
can
new rules? Okay, so you have to
they
be
can
full
change
dual,
to align.
otherwise forget about it, right?
If you are full dual, yep, you can change to align, or if you're partial dual, you would have to follow these enrollment periods that are set by Medicare.
And same for changing drug plans, that someone who's just QMB, original Medicare QMB with a drug plan can't change drug plans until next year too.
No,
They would need to.
They could change their Part D plan any month.
Oh, if they're using original Medicare and a standalone Part D plan, then they can change every month. It's just people in Advantage plans can't change.
Right, because the people that are in original Medicare, they're going to have extra help, and they're allowed to change their Part D plan monthly.
But don't people in Advantage plans also have extra help?
But it's only for Part D plans, for standalone Part D.
Oh, for standalone Part D. Oh, extra help in a standalone Part D. Not
Right.
extra help in itself doesn't qualify them. Okay.
Right, they can change a standalone Part D coverage monthly.
Every month even.
Yeah.
Okay. It's just that if they're in an Advantage plan, no.
Right, exactly.
Thank you very much.
Maureen, let's get to you before we forget you again.
That's okay. I am totally lost, and I've been doing this a long time. So I think it would be, for me, it would be useful if we walk through scenarios. Because the typical person for many of us, a typical person is one who's transitioning to Medicare from Medicaid or from the ACA, or a person who's just turning 65 and we need to give them the options. I as a counselor, want to know what the options are for people in different circumstances. And I'm not clear from all this conversation about trying to align plans and having separate BHSOs and whatever, how to guide the clients the beneficiaries that I will be conversing with. And so it would be helpful for me if we had a session. You probably have an agenda for today, but a session where we have a scenario where I can come in as the beneficiary and I want to know what my options are, because that's what I, as a counselor, need to know to tell this person what all their options are. And I'm not sure that I know what their options are and why it would be beneficial for them to be on a D-SNP versus something else. And if they don't have an assigned BHO, whether or not they're going to be able to get, and they all of a sudden at 67 need mental health counseling, whether or not the plan that they're looking at is going to be best for them. So I don't know if I'm just dense today, but it is overwhelming. So thank you.
Happy to do that. I think that if that's going to help, then certainly we can look at the different scenarios. If folks want to give us some scenarios that they're bumping into in terms of general scenarios, I'd like to keep it high level. So if you're thinking of a unique scenario that affects a very small portion of the population, then while it's certainly good to talk about for any initial conversation, let's focus on the majority of individuals. That way we can clarify some of this confusion out there.
Absolutely.
Yeah, that'd be great.
Well, and
Victoria,
I think,
go
sorry,
ahead,
Johnny.
Vanessa.
I was just going to add that prior to scheduling this lunch and learn, I understand that we did request that folks submit their questions ahead of time so we could make this more meaningful to the work that you all are doing. So just putting that out there for future, just make sure to submit those questions ahead of time and we can make sure to have them ready for you when we meet.
Yeah. So I think, and you guys just jump in, but I think the most common thing that we see is the person who's been on Medicaid. Maybe they were on Magi Medicaid and they come in because they're switching to Medicare now, and they just don't understand how it's going to be different and what their different choices are. They just got, like, for me at least, the most common thing that I hear is it's usually someone who's an MSP only. But let's do a full dual so that we can talk about that alignment, because that's really where the big confusion is here. Does anyone add anything besides that? They're coming in and maybe they're SLMB now, where they had full Medicaid before. Now they're SLMB. Or no, wait a minute. No, I'm sorry. Let's say they are full Medicaid, because we want to talk about that BHSO and the alignment, right?
Let's talk about that for a moment, because I think I want to understand better. Again, recognizing that Medicaid has different levels of different doors that somebody can come into to qualify for services. To be very transparent, how an individual qualifies for full Medicaid is going to be really based off their income levels, as many of you know. So, for example, the Affordable Care Act, the expanded Medicaid, has a different income level than your classic Medicaid, more of your based off of the federal poverty level. So you will find cases where somebody was eligible for Medicaid under the Affordable Care Act, or MAGI as you may hear them called, that when they transition into Medicare, their access to Medicaid will alter because the income levels to qualify for that expanded Affordable Care Act are change based off of that, how they're being assessed for their current under their Medicare rules. So if that is a highlight for you, then certainly we'll we're going to want that question. We're also just going to want to make sure we have the appropriate experts to talk about how that adjustment occurs.
Yeah, let's start with full dual eligibles though. Someone who's on classic Medicaid and then they become eligible for Medicare. And how we can help them as SHIBA counselors understand the changes that they're going to experience in their care. Does that seem
Okay.
like a pretty general one? Anyone want to shake their head that they would have had that, or that seems like a common thing? Okay, Larry's giving me a thumbs up.
So Vanessa, let's take that one back and maybe we can use that as a starting point to develop some guidance documents that might help. Would that be okay, Vanessa?
Oh yeah, sorry, I just get fumbled on unmuting myself. Yeah, no, I think that's great. So we're kind of, it's the confusion around the actual transition from Medicaid into Medicare. Yeah, I agree. That seems to be a sticking point for a lot of folks.
And I see, Arlene, I see your comment under there. So it seems to me there are two types of Medicaid for people under 65, Magi, and age blind disabled. I would also like to know what we need to know about transitioning from each type. So we will capture that. David, you asked what BSO stands for. It's BHSO, Behavioral Health Services Only, meaning that it's a managed Medicaid plan that handles an individual's behavioral health services only. Again, your physical health is handled under Medicare, so that's where BHSO comes from. Just looking through all these comments.
Well, the reason I asked is because I wasn't sure. I had seen BSO as well as BHSO, so I had seen it without the H and I didn't know what that stood for.
I'd have to see BSO in context. I apologize. We use a lot of acronyms and sometimes they can mean multiple things. So if you were at a website or something for context, I might be able to answer it better.
Well, I saw a comment in the chat.
Oh, okay. I think in that respect, I would have to check with the commenter, but they might have been meaning to say BHSO.
I think that's exactly what it is. They just missed the H.
Let's see. Also, how does HWD affect things during the transition? That's healthcare workers with disabilities. So we will take that one back as well. I'm thinking, Vanessa, some sort of swim lane process.
Yeah, agreed.
Visio mapping is always fun. Maybe some pictures.
Yeah.
I don't know if we can fit in some theme music.
Excuse me, can you hear me? This is Connie, and I would
Yes.
like to volunteer to work with y'all on that. I'm a SHIBA volunteer, and I'm also a former business systems analyst.
Excellent. When we do have, and let me just stress this as well, Vanessa runs a monthly I'm sorry, it's bi-monthly now, is it not, Vanessa? Every other month?
Are we talking about the SHIBA?
Yes.
Yes, so it was monthly. It's now a quarterly, where we get together as a group. It's a collaborative. In fact, it's called the SHIBA Quarterly Subwork Group Meeting at this point. It's a collaborative with DSHS, Healthcare Authority, SHIBA OIC, sponsors from around the state that have the SHIBA contract, many VCs, other community partners, tribal entities, 211 as a resource as well. We all come together and we get updates, but we also do a lot of problem solving in these sessions as well. If you have not been notified about the meeting, I think Noreen would be able to forward the invite to anybody that requests it from her.
just want to make folks aware that that meeting exists, and it's also a really good resource to hear from other experts around the state in some of these questions.
Right. I'll talk to Noreen about what I had in mind. Okay, thank you.
We'll add that one, Abby. Another common transition occurs when a Medicare beneficiary loses full Medicaid after recertification. So we'll add that one as well. I think that one is a common one where somebody finds that they are no longer Medicaid, and while they may remain in a D-SNP for a period of time, this is called the deeming period, while they seek to regain their Medicaid eligibility. It is one that certainly we'll put as one of the options. And Connie, I see your email address, so we'll capture that.
I got it, Connie. Thanks.
Thank you.
And again, I would also invite you to check out the links that we put in the chat box as well. Information around Apple Health Medicare Connect, or D-SNPs as they're called. And then of course the Medicaid plan. There's lots of information about BHSOs in there as well that may help to alleviate some of your questions.
Oh, and Connie, I just want to let you know, I think is the your volunteer coordinator, Sam, I think.
Yes, he is.
Okay.
I'm with Solid Ground, but I was thinking about a training thing. I'll talk to Noreen later. Okay.
Oh, okay. Well, I just wanted to
Or
let you
Sam.
know.
Yeah,
Yeah,
or Sam.
Stan was not aware of it apparently, so I just looped him in. So you could also get that information from him as well.
Right. I'm thinking about something, a solution going forward, a
Okay.
business systems kind of thing. Thank you.
Gotcha. Thank you.
All right, I'm seeing a lot of questions, but I think that the idea of handling those and kind of mapping those out for you will help answer a lot of these questions. And so I think, again, I'm just trying to make sure that we're being responsive, that we have a good starting point for the next time we meet with you. Is there anything that we're missing, folks, from your questions that you really want us to focus in on? Okay,
Larry,
so
go ahead.
go ahead, Larry. Yeah.
Yeah, thank you. SHIBA's evaluative process is really focused around straight medical care insurance. But many times we have people that are dual eligible and have a BHSO option on the side. Ask us to help evaluate what is the best, most effective BHSO type insurance plan. And I have no way of doing that. Is there anything out there that is similar, say, to the Medicare Plan Finder that would help us evaluate one behavioral health services only plan compared to another?
All the BHSOs, the Medicaid plans, offer the same services. So they all offer the same, they're required to offer the same services. There are what are called value added benefits that each of them may have that that are related only to individuals who are enrolled with the plan. They're not allowed to market those in any way. However, you also have the Washington Apple Health Plan report card. I will put that link in the chat box for folks. It's also another option for individuals to assess satisfaction with the plan. So it really comes down to, again, for their Medicaid benefits, it's all required. All of them are required to provide the same type, same level, meet the same expectations. Administratively, there may be some differences in how they process their requests or even their networks that can be different. So if you're looking at a different plan, you may need to look at their networks. You may need to look at this report card that I put in there. You may need to look at just the again, focusing on the network, who they work with, and how much, I'm gonna use the word penetration, but how many providers actually work with them. So that may help in their work. And then when you're looking at their D-SNPs and you're looking at that on top of that, their supplemental benefits also provide you with a good value in terms of what they're offering. Again, Medicare requires them to cover all the Part A and Part B services, but their supplemental benefits give them, which they can market, give them added value to an individual who's seeking a plan that's going to help them in their community. So if dental is a key component, they're gonna look and see what plan in their county offers a dental benefit that meets their needs and is covered, and we'll see them at whatever provider they're working with. So between that kind of evaluative process you're talking about, you'll find what is going to provide them the wraparound care that they're going to need. Just checking to see if there's any more questions. It's 11:53.
Yep.
Can we get these companies to realize that within 50 miles for assignment of PCPs to Medicaid patients does not work when the Puget Sound? I recognize and understand that question. I am constantly asking them that same thing. The definition for Medicare Network Advantage is based out of CFR. The definition for Medicaid network adequacy is based out of both our contract as well as CFR. So there are some federal rules in how that's analyzed, and there is additional requirements in terms of on both our contracts. So I will just share that in our state Medicaid agency contract, we do require that 80% of their Medicaid network also sees Medicare clients. So if they are offering a Medicaid plan in Jefferson County, then we would expect that 80% of the providers who see their Medicaid clients also will see their Medicare clients. So we're hoping to create that kind of consistency and overlap that as someone transitions from Medicaid to Medicare, they will be able to keep their providers. But we do acknowledge that there are limitations in terms of how Medicare looks at network adequacy and how Medicaid looks at network adequacy. So you're right. There may be PCP providers that are within the federally mandated network adequacy that are across the sound, and it may seem like that's within an hour's drive, but really when you throw in the ferries, assuming that they're running on time and that in some cases they're running, you can get to your provider. I'm trying to be very transparent and just say, we understand and we agree with you. We're working on some different pieces, but I want to just emphasize that network adequacy is determined a lot around the federal rules that are associated with that. Pausing to see if there's any more questions. I'm looking at the clock, realizing we're just a few hours from totally recognize that, Nancy. I understand that a trip to Marysville is not an easy thing. We're looking at 11:56, so why don't I return it back to you, Noreen, because I think we're coming up to time, but I will, again, Vanessa and I are very open to questions, so if you want to work with with Tim and his team or with the SHIBA trainers, we're happy to accept your questions and get a response to you as quickly as is feasible.
All right. Thank you so much for your time and being so open to questions, and for joining us, Johnny. I think this is Johnny's third appearance, so he gets the special prize. I don't know what that is yet, but we'll figure it out, right? And Vanessa, thank you for joining us for the Lunch and Learn today. Thank you, everyone else. I have been copying the links out of the chat and I'm going to send it to everyone who's in here, all participants. Check out if you're looking for those videos from last month's when we talked about the spend downs and D-SNPs. If you are looking for that video, that is posted on our website now in the video trainings, and there are some other ones there. Check that out. And in the meantime, we will I'll talk to Johnny and Vanessa about the questions today and what we can look forward to going forward. And I'll share that answer with all of you when I get that too. Okay, about what they're going to come up with and how we'll get that out to all of you. Okay, if you have any questions that you want to do in a group submission, please feel free to send me questions that we can forward on to them. We try to do them kind of in groups, so that's helpful. But if you have an urgent client question, then by all means send that too, and we can send that on to them or whoever it's appropriate that addresses that.
Thank you.
Yeah, thank you, everybody, for joining us.
Thank you.
Thanks, everyone. This was fascinating.